The Curbsiders are now partnering with VCU Health Continuing Education to offer CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Well, Paul, we are back. We have done it again. We just got finished recording an episode on medical myths with Dr. Douglas Paauw, and with us, Stuart's not here, but with us is the great Dr. Justin Lee Berk. Justin, you want to say hi to the audience?
So happy to fill in for Stuart. Grateful to hear everyone and see everyone again. It's great to see you guys.
Yeah, big shoes to fill. I think you did an okay job, though. Paul, how about you tell the audience a little bit about what we do on this show, and then Justin can tell them about our fantastic guest.
Yep, happy to. As always, we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And as per usual, this seems to be a theme recently, we're finding out all the things that we've been doing wrong our entire careers, but did not know that we were doing them incorrectly. But I'm going to let the great Dr. Berk talk more about our guest and how he schooled us on all the things that we thought that we knew.
Another day in the office. We had a fantastic conversation with our guest, Dr. Doug Paauw. He is a primary care internist who has been the director for student teaching for the Department of Medicine at the University of Washington since 1991. He's currently professor of medicine and the Rathman Family Foundation Endowed Chair for Patient-Centered Clinical Education. He teaches us why it's okay to drink alcohol while taking metronidazole, while it's okay to take some inspired medications, and why sinus headaches are really just migraines that can be treated with migraine medicines. Without further ado, let's get to it. He did a great job. It was a mythical performance.
Yeah.
I mean, that was fairly horrible, so I feel like it's in keeping, so congratulations.
Feel like Stuart's here. Doug, thank you so much for joining us. We've agreed to drop the formality, so we'll call you Doug from here on out. The audience, I don't think you've been on the show before, so can you give the audience a one-liner about yourself and maybe tell them a hobby or interest outside of medicine?
Yeah, my name is Doug Paauw, and I'm a professor of medicine at the University of Washington. My great passion is teaching medical students. I've been the medicine clerkship director for over 30 years, and I guess my favorite hobby is being a new grandfather, and I'm got a very quirky and not socially acceptable sense of humor.
You'll fit right in, and congratulations on being a grandfather. Yeah, congrats on both. That's a better way to say it, Justin. I'll leave some room for my colleagues to ask you some questions.
I feel like it's been a while since I've actually asked for a book recommendation. I feel like we usually gloss over this part. And now that I have so much free time at home on my hands, I certainly load me up. So it doesn't even have to be a medical book, just any book that you think that someone might enjoy. If it's directed towards physicians, all the better, but it doesn't have to be.
I really like the book Being Mortal, and I know a lot of people have read it. I being a general internist who's been in practice so many years and my patients have aged with me, I'm really seeing so much geriatrics and just the idea of we all get older, as well as myself getting older. I think it's a incredibly easy read and just has some lessons that are really important for everybody.
Yeah, no, great recommendation.
I like that. Everything he's written has been really good.
My other one that maybe because you guys are all so young, you may not have read, it's The Band Played On by Randy Schultz. It's about the early HIV epidemic back in those days where it was always called the AIDS epidemic. And it's a very compelling, and I think especially in this COVID age, I think it's a remarkable book, and I think it's a real page turner for people.
Another top rec. These are good. One of my favorite questions that we ask is always about the advice question. Can you tell us a piece of advice that you received either as a learner or as a teacher or sometime throughout your career that others might benefit from?
Yeah, I think it's the best advice I ever got is don't try to look good, be good. As somebody who works a lot with medical students, I think it's very hard in training, and we always want to put our best foot forward, and they're like everybody's looking at us and watching us and grading us or evaluating us. And the point is, if you go to your core and you do the best you can to be as good as you can in whatever you do in life, it will show, as opposed to what is the external world going to look at me for? And I think that core value is huge. And I was taught that, and that was about the best piece of advice I've ever gotten.
Awesome. I don't know that we're going to top that one. Before we move on to the full show, Paul, did you want to give a pick of the week?
I feel like I was surprised by this. Sure. Did I recommend the Lagunitas hops refresher before?
No.
That's a new and fun one, especially since the weather's warming up. So as you may or may not know, I love beer, but also don't drink alcohol, which is a terrible combination because most non or low alcoholic beer is just the worst stuff on the planet. But there is Lagunitas, which makes a really fantastic alcoholic beer, also makes a really good sort of non-alcoholic hops refresher. So if you're someone like me who likes beer but also doesn't want to be bothered with alcohol, it is a delicious taste treat. So I'm going to recommend, rather than some weird movie, I think I'm going to recommend a non-alcoholic beer this week. So please to enjoy.
Okay. Justin?
I don't have one this week. Still keep the thing moving.
Okay. All right. Let's get into a case from Cashlack Memorial. Justin, I'll let you do the honors.
All right. Well, actually, if you don't mind, Matt, I thought, since we have Dr. Paauw here, we have Doug here, who is going to talk a little bit about medical myths. And this was originally going to be at the ACP conference, which we are not in attendance as originally planned due to COVID. I was hoping to ask Doug if he could tell us a little bit about what are medical myths and why do they occur? Why are they so prevalent in medical practice?
So I use the term medical myths for things that they may not all be true mythical in the sense that they're things we hear about that are absolutely not true or legendary, but without stuff. They may be something where there's evidence for another way, but you're trained in dogma that you only do things one way. So that's kind of the definition of it. Why do they occur? I think there are three things that I think about as far as why they occur. The first one is thinking about physiology that makes just so much sense. In medical school, we may be taught something that is just pure physiology. It's clear. This is easy to learn. We got this. And sometimes in the body, there are more than one or two things at play and not things as simple as maybe we were taught in medical school. Another real common cause of medical myths are case reports. That case reports can get into journals based on, hey, I saw this, I want to alert the world about it. And they are incredibly helpful for us all to know that possible things can be breaking and we need to know, sort of breaking news. But case reports do not get the same scrutiny. They're certainly not the same as a randomized controlled trial. So they get into literature as truth, even though maybe they really didn't show what they thought they showed. The other one is just tradition, the word of God, that this is the way it's been since the beginning of medicine. We never did randomized trials, but we've been doing this for so many years that this must be true. So those are kind of the boxes that most myths fall under.
You know what struck me as I was prepping for this? A lot of the articles that disproved some of these myths were like between 10 and 20 years old. So
right.
We're not exactly like, quick to on the uptake, I should say.
Absolutely, and many are even older than that. And sometimes when I lecture on this, I will get feedback before people hear the talk, and they'll say, "Could you update the references?" And it's like, well, they proved this so many years ago. It's not like people keep going to reprove that it's not true. And it is hard to adapt sometimes.
Paul and I just did a recording yesterday talking about that atelectasis does not cause post-op fever. And that's been, since like the mid-90s, easily you can find articles. And I literally have had people suggest that to me on rounds in the past year still that are in medical training, so that you would think they'd have more up-to-date information than me. But
what? I guess another category is a mnemonic where something fits nicely into. It's hard to get rid of that. So I think just the fact that wind is right there, like it's just hard to sort of shave that off.
Yeah. I think the inertia too, just like as an intern, when you're taught so much information, it's tough to like critically analyze every pearl that you're taught. That something just wind up getting stuck in there, even if there's not the evidence behind it.
And when we start out, we want to have some rocks to hold on to, right? I mean, we are a clean plate. We're a clean palette there, and we want to say, okay, this is an anchor. I got this. And somebody tells us something and we learn it. It's hard to let go of that.
Yeah.
Well, so I'm excited to get in because I was impressed by some of these. These were great. So let's say we're in Cashlack Clinic. It's a busy day, and your first patient's eagerly awaiting you in exam room 4. Mr. S. O'Toole, he's a 32-year-old gentleman. He just got back from a bachelor party camping trip last week and was diagnosed with giardia. No other medical issues. He's been prescribed metronidazole for the giardia, but he's best man at his brother's wedding tomorrow, and he wants to know if he can drink. Classic Dogma would say, no, you can't drink on metronidazole. What advice would you give him regarding alcohol use and metronidazole?
So I would just, the short answer is I tell him, yes, he can have something to drink if he wants. I probably would encourage him not to get, drunk to the point of passing out. But if he has a few drinks, that probably is very likely to be very safe for him. The Dogma is on his prescription bottle for metronidazole. When he got it, there's a sticker on it that has a little martini glass with a slash through it. And so that is given by all pharmacists to this day. And most physicians will bring this up and discuss it with a patient, or maybe the patient will read about it on the internet and then call the clinic and say, is it really true that I can't drink? And the vast majority of medical providers will say that's true. You can't have any alcohol when you are on metronidazole.
So we just tell him that, what was that? Lagunitas hop refresher, Paul? That's what,
yeah, this is what I'm saying.
He's going to be stuck with Paul's alcoholic beer.
Maybe they could sponsor this episode, Paul. We'll reach out.
Fingers crossed. Oh my God, that would be amazing.
Get him to send you some cases. Yeah. So how long should we have known about this, Doug? How long?
So there has been questions about this since the 90s when looking at case reports of this potential interaction, it found that, you look at the case reports and they didn't really measure the things we want to measure. They were basically the story of somebody was on metronidazole, they drank alcohol, and they threw up and got sick. I've never seen that with anybody drinking alcohol before. Or taking metronidazole for that matter, right? And it's like, gee, you combine two things that can make you puke and get diarrhea and feel like crap. And so, but it was all like, yes, we see this, because it had gotten in there years before. Back in the 50s, there was a thought that metronidazole, 50s and 60s, that metronidazole could cause a disulfiram-like reaction. And so that was accepted because we all knew what disulfiram was. It was something that was given for patients that had alcoholism, and if they took the disulfiram and then they drank alcohol, they got sick. And if they took it, it would magically make them not crave alcohol because they didn't want to get sick. So once this link was made between metronidazole and disulfiram, it was accepted as dogma. And so these case reports came out of it just saying, yeah, we've seen this. And that just further cemented this idea. And I believe it was in the 2000s, an article came out that was a really nicely done article, but it was very small. 12 very healthy volunteers, rumored to be medical students, just FYI, who were offered plenty of alcohol, and all 12 of them got alcohol. Half of them were given metronidazole for 5 days, which was important beforehand. The other were given placebo, and then they all got the promised alcohol, and their blood alcohol levels were measured, all their symptoms were measured, blood acid aldehyde levels were measured, and lo and behold, they found no difference between the groups who had been on the metronidazole for 5 days and the group that had been on placebo ahead of time. So there were no reactions whatsoever in 12 healthy volunteers. And that is the world's literature on actually challenging people.
So I just want to reverse, and I just want to check in and find out how gullible I've been, or exactly how happy I am to listen to authorities. So I just want to make sure I understand. the disulfiram-like reaction, which is fun to say and feels very satisfying and pathophysiologic, we just reverse engineered that from the fact that people threw up when they had metronidazole and alcohol together. Like, no one actually studied whether or not it acted like disulfiram. Am I understanding that correctly?
No, the earlier studies actually looked at, this, people thought, hey, this seems, somebody thought it was a good idea to look at, and then they looked at it like, could metronidazole have the same effect as disulfiram to prevent people from drinking? And in those studies, they discredited that it didn't appear to be something that was helpful at preventing people from drinking, because it wasn't a side effect that was like disulfiram. But those studies got lost in the literature. They got forgotten about and didn't get pushed down. More studies have happened since then in rat models, and rats are good to use for this because you don't have to get informed consent on them.
Right. And they love to drink.
They love to drink. They'll eat anything, right?
At least in Charlotte's Web would tell us they love to drink.
So in the rat models, they found that there was no inhibition of aldehyde dehydrogenase, which was the magic bullet that had said, well, this is what causes all of this. So that was known. So all of this started to fall apart before that small controlled study. So
is there anything else that we need to know on this, or is it just basically this is a myth? Don't worry about it. That's one less thing to counsel patients about when we're giving them metronidazole.
The only thing I think about in this case that you presented was that the issue is, in a healthy person who doesn't have a lot of medical problems, that's the group that was studied. So I think in that case it is a myth. If they have a few drinks, they should be fine. The concern is, how about people with so many other medical problems? That group hasn't been studied. And sort of an intriguing study in rats again was they didn't find that the blood acetaldehyde levels went up when rats took metronidazole and alcohol, but they did find that the GI tract acetaldehyde levels could go up, with the idea that bacteria can be selected for that are actually bacteria that can change the metabolism of alcohol a little bit. So the issues in the study, in the human study, they didn't find any difference in blood alcohol levels or acetaldehyde levels. But could there be an issue actually within the gut that might make some people that are prone to this get a little more diarrhea? That's certainly a possibility that hasn't been ruled out. But to get back to your answer, yes, I think for healthy individuals, having a drink when you're on metronidazole is okay. One other thing is a rumor, and I think from a very credible one, that it looks like on the next CDC STD guidelines, when they talk about metronidazole, things like BV and other things, that they're going to remove the alcohol disclaimer.
Awesome.
End of an era.
Yeah.
It only took 25 years.
My big takeaway is that if you are taking metronidazole, you can drink as much as you possibly want and will not get sick and vomit. So
I was going to say, we should be careful how we revise our counseling.
Great.
Well, we'll see how that works for you.
I think they gave the medical students it was like what was it? It was 4 grams per kilogram or something like that. Or no, actually, don't quote me on that. I'm going to.
Per kilogram.
How much was it?
Grams.
0.4
grams per kilogram. I don't know what that is, though.
So 100. So your standard 100 kilogram medical student got 40 grams. I think a standard drink is around 14 grams. So it's like, that's around what, 3 to 4 drinks.
So their blood alcohols got over 0.1. That was kind of they got them legally drunk, or at least, in trouble with the law if they were driving. So, they got it up to a what would be considered by society a intoxicated blood alcohol level.
Okay, great. Okay, Justin, what do we have next here?
All right. So our next patient, next room, is Miss Sarah Bottles. She's a 55-year-old female who's traveling internationally next month, and she wants to replace her emergency travel kit. She has medications, including ciprofloxacin, loperamide, and oxycodone in this emergency kit, and they've all expired. So she's asking if you would send a refill in so that she has these medicines on hand. So what do you do about this type of request? Are medications active after their expiration date? Do we need to replace them every time they expire?
No, I would, first of all, these requests always come at the end of the visit, right? So you've spent all your time going through 4 medical problems and really counseling your patient. You're running 5 minutes late, and it's like, oh, by the way, one other thing I want to do today is get all my travel medicines or my emergency kit refilled, and that takes a few minutes. So that's always kind of a bummer. And I think the bottom line on this one is you don't need to. These things are inert. They can be around for, forever, basically. And the important take-home message, which I'll give before we go through the data, is that most of these are PRN drugs. These are not their most important medicine that they take every day. These are things for if they get diarrhea, if they get pain, if they get, some other exotic, weird symptom when they are away from home. So there's not much harm if these things dropped a little bit of efficacy, but interestingly, all the data is these things tend to be just fine for a long time.
It seems like there's such a, I think of this as like there's no incentive for this to be heavily studied because so many people are making lots of money by expired medications being thrown out and refilled. I don't know why the pharmaceutical companies would want to like fund any studies to prove this.
So that's what I've always thought. And then I started to read more editorials on this stuff. And the interesting thing is when all these things go bad, including in the warehouses for the pharmaceutical industry, they have to toss them. And so I've always thought that's absolutely a correct assessment that, like, why would anybody want to say this stuff's good for 4 years when you can get people refilling it every year and a half? But some folks that look at this say, well, it's a little more complicated than that. But I certainly don't think they fund the research on this. The research on this actually came from the military because the U.S. military has to stockpile lots of drugs for all sorts of occasions. And you can imagine the cost if every year and a half or 2.5 years you have to dump your stockpile of stuff that's unlikely to be used for a long time. So they were the funding source for the biggest study. The biggest study out there looked, I think it was like 3,000 lots of different medications, and they looked at when would it be 90%, when would it drop under 90%? 90% potency is what's required by the FDA for these medications. It doesn't mean do they work or not, it's just when do they drop below 90% potency. And so companies will just study at a year and a half. If they're above 90% potency, they'll say we're good. A year and a half is good, but nobody looks at beyond that. So in this study, they looked at that, and surprisingly, they found that the majority of what they tested, almost everything they tested, had 3 to 5 years plus at 90%. And they tested a whole host of medications, antibiotics, painkillers, most of the things you would probably find in a travel kit.
So I feel like the clinician concern would be that you would lose efficacy. I feel like the patient concern, at least in my limited experience, is that they're worried that the drugs become instant poison once they're past their expiration date. So are there any medications where we should worry about toxicity if they're sort of past the point of expiration?
Nothing beyond the toxicity of the drug that a person will happily take anyway. I mean, I have patients that want they want like an oxycodone prescription because when they're hiking on a 15,000 foot mountain peak and they break their ankle, why not pop an oxycodone for the pain? I mean, that makes a lot of sense. But no, the answer is no. And where this came from is back in the 1970s, 60s, 70s, there was a formulation of tetracycline that would get toxic when it would break down over time, and it could cause a Fanconi's syndrome. And that formulation of tetracycline has been off the market since the late 70s, early 1980s, and no other pill form drug have we found any toxicity when they're expired as far as breaking down to something horrible.
Should we exclude, I was reading from your slides, it looks like aspirin does break down, and then the classic one that I always tell patients about is once they open their sublingual nitroglycerin tablets, those ones seem to lose potency. were those excluded from these recommendations that, most meds are okay past expiration?
Yeah, so the study you're talking about with the aspirin is a fascinating study where they went way beyond what the military looked at, which was, let's look a few years after. They found some boxes of meds from 28 to 40 years before. I mean, these are your grandparents' meds, and they found boxes in a pharmacy and they tested them, and they tended to be combo meds, drugs like Fioricet, Fiorinol. These combo, have multiple different drugs in them. And what they found was everything, even 40 years later, were at over 90%, with the exception of aspirin, and aspirin broke down to less than 1%. And the good news there is most times we use aspirin for a useful endeavor, such as for cardiovascular disease or something where we really need to have somebody on aspirin every day. It's unlikely they're going to be using really old aspirin. But I agree, aspirin is one you'd say, if you need the aspirin and it's important to you, you should probably keep that fresh. Nitroglycerin's another one we've been taught, and it's, we've always been taught if it doesn't sting or feel funny under your tongue, that's probably time to get new nitroglycerin. And I haven't seen a study on that. I honestly can tell you I haven't looked for that one, but that's probably reasonable advice that if you don't feel it, it may not be as potent. But that will be something I'll put on my short list to look up.
And the shorter term studies, not the decades old ones, because I think that one looked at unopened sort of pristine medications, but the shorter term ones, they look at open packages as well. Can we extrapolate that? Because usually I have patients I had a couple of these left around. It was expired, but I took them anyway. Not these emergency kit situations that we're talking about. Can you extrapolate this to open medications?
Well, the open only study I've seen where they've looked at that was an eye drop study, and that's another topic that people always ask us, because eye drops are they actually are more valuable than gold per weight. They're so expensive, and people don't want to have to toss their eye drops. And in the eye drop study, they looked at ones that had been opened, and was it still effective 12 weeks after the expiration date of an opened eye drop? And it was travoprost, I believe, was what was being used. And they found that the lowering of eye pressures was equal in those of the opened expired eye drops compared to the nicely still secured eye drops. But I haven't seen any studies of pill form with that. The other one that is just kind of left out there is epinephrine. And there was a study looking at physicians and medical professionals who just, for this study, just gave their old epinephrine that was lying around the house, EpiPens, or lying in their car or in their office or in their garage, wherever it may be, not temperature controlled or anything. And they looked at, was epinephrine still effective? At least they didn't do a test to see if it was truly effective. They measured the amount of epinephrine that was still viable. And they found that at 40 months, many of these things still worked. 2 other epi studies looked at about 2.5 years. It seemed to be okay. But that's one that we're still a little nervous about, because the outcome of bad epinephrine in somebody who needs it is a lot different than bad oxycodone, right?
Right, for sure.
Yeah. So as far as the epinephrine pens that are EpiPens that are beyond expiration, we're not just recommending that patients like use those and feel like that they're safe. It's probably better than nothing if that's all you have and you're having anaphylaxis, but you'd still go to an ER, but probably still keep your EpiPens up to date. Is that what you're saying?
Yeah, I think that I tell my patients, don't toss those EpiPens. If you have 4 or 5 places, you can put those in your backup places just so you have an EpiPen if you don't have your other one always with you. But we haven't gotten to the point where we feel comfortable saying it's fine to use all these expired EpiPens. I do think we will at some point be able to extend the expiration on those because of how expensive they are. But I tell people don't throw them away, but use them as a backup.
And this came into question. It was like 2017 when the EpiPens made a huge jump in price over that like decade period. And then there was a research letter in the Annals that was talking about these expired EpiPens. And I guess that's where people really started looking at it, because it's not a trivial expense. If the medications are unopened, it seems like they can go way beyond the expiration date. For open medications, other than eye drops, we just really don't know. So if someone's got like lisinopril that's in the bottle they got from their pharmacy and had been opened and they find it 3 years later, who knows? So I would be a little hesitant to tell the patient with like advanced heart failure that, okay, that lisinopril is fine. But Doug, do you have any clear guidance on that? What do you tell people?
I think that's a good point you made. We don't have data on that, so we would be extrapolating without data on that. And for anything that important, I think that I would advise a person probably to get a new prescription, especially if it's not going to be harmful financially for them. The only exception might be in the cases where the person has found some old medications that they won't be able to pay for the prescription. And, a good example of this might be if somebody's lost their insurance and they have they got 3-year-old Eliquis, for example, and they're going to say, I'm not going to be able to buy this, but, I'd say, well, you probably should just go ahead and use what you got until you can come up with money to buy a new prescription. That would, but it's not based on data.
Right.
Okay.
Great. Does one of you guys want to give the next example, next case?
No, I think if you wrote these names, I think that you should.
All
be
right.
one
I kind of wanted you to have to say it, Paul, but
yeah, absolutely not.
I'll do it. All right. So your next patient is Alexa Payne, and she reports some frequent headaches over the past 12 months that include pressure pain on her forehead, under her eyes, and right over her cheeks, in her sinuses. She usually has some nasal congestion as well. She's not had any fevers or purulent discharge. And so I just wanted to talk about, is this a typical sinus headache? What is a sinus headache, and how should we treat this type of headache?
This is super common for people to come in and say, I got another sinus headache, and can you give me what works for me? A course of antibiotics, I'll take my decongestants, and I'll be okay in a couple of days. And these calls come into doctors' offices all the time, requests from patients very frequently for this. And I think this patient probably has, and I think with a high probability, a variant of migraine headache and not a sinus headache, and that recurrent sinus headaches, if they exist at all, are quite rare. The headache experts certainly believe that, and that this is very likely a migraine headache, and we should be treating it like a migraine headache.
I have to confess, this was totally not really on my radar as a myth that was out there. And I'm just thinking back, I noticed again in your slides that the patients complaining of sinus problems, maybe they're not even complaining of the headache as much. They're just complaining of kind of discomfort in that region and not calling it a headache. And I wonder how many of these patients I've missed, or I should have trialed like a migraine medication to see if that relieved their symptoms. I was embarrassed when I was reading this, and the delay in diagnosis that you quoted was 7 years or more, something like that. Can you speak to that?
Yeah, so there's one study that looked at individuals who had these types of sinus headaches who ended up with migraine, and it was a long delay, 7 years, and that's not uncommon, because this one, the studies that really address this came out in the 2000s. I think like 2004, 2006 were some of the studies, and this just hasn't made mainstream primary care headache information. This one has really dodged it. And when I talk about myths and present these for audience response, only about 20% of people will pick migraine headache. Most people pick sinus headache, and so I think commercials for years showed throbbing sinuses causing pain. Our patients tell us it's their sinuses. We've all had our sinuses kind of ache when we had a cold or something, so it all makes sense. These headaches must be coming from the sinuses. What is actually happening with these migraine headaches is that the trigeminal nerve, one of the divisions, is getting impacted, and that provides sensation to the sinuses. So the feeling is in those sinuses. So it really is a sinus pain, but it's just not happening from a sinus infection. The other thing that is striking in these studies is that people can have bilateral sinus pressure and pain, and we don't think of that with migraine, right? We think of unilateral. That's one of our key migraine things. And for this variant, it's not uncommon that we'll be bilateral. So that throws us off too with the diagnosis.
And so it sounds like, with these cases that come in with sinusitis, it seemed like sinusitis, but not an actual infection. Treating like a normal, typical migraine might actually be more effective. Is that right?
Yeah, so the pearl here is if it's recurrent. People say, a couple times a year I get these sinus infections, or 3 or 4 times a year, or my goodness, this has been a bad few months, I'm having one a month. That strongly suggests migraine. If somebody comes in for the first time ever and they're 35 years old and they have a fever and they have chills and their sinuses hurt like heck, they may have a bacterial sinusitis. That's certainly a really bad pain with that would not be an unreasonable thing to think about as a diagnosis, but it's this repetitiveness that happens in so many people. Like, a couple times a year I get this sinus headache. And people with migraine headaches, other formats can get this too. So they may have typical migraines, but they just need to know to try their migraine meds when they get one of these too. So there can be an overlap between already diagnosed migraines, but they still get their antibiotics and decongestants when they come to the physician with this set of symptoms. One study looked at, let's just treat these people like they have migraine and what happens. And so in that study, and there's some fascinating stuff about the study. So they recruited roughly 50 patients and they had a big dropout rate. And what they did initially was they said, okay, everybody who is self-diagnosed, physician-diagnosed sinus headaches, we are going to CAT scan you and do endoscopy of your sinuses to see if you really have anything going on there. They wanted to do it well and make sure that they weren't just throwing everybody into one kettle. So they did that, and the group that they did all had good-looking sinuses, and the next step was they're going to treat these with migraine-related directed therapy. Mostly triptans were their first line, and they had a big dropout rate because those people were angry that, you don't get it. I have sinus headaches. What kind of whack jobs are you people? And so I thought that was pretty interesting. And so the dropout wasn't because of failures. It was because before they even got to the, medication arm of this, they were, these patients were told they didn't have sinus headaches, that they wanted to treat them for migraine because they didn't have true sinus headaches. And so, but anyway, the brave people who actually went through with this, they had a 92% effectiveness of migraine-directed therapy, with the majority of them responding to triptans in the 80s.
So I would take away from that, you got to be gentle when you are suggesting to a patient that maybe it's not all just the sinuses. Maybe there is migraine contributing to this as well. Sometimes people are hesitant to let go of a diagnosis that they've been given.
That's great advice. I think gently saying, hey, this happens to you all the time, and you always have to come in here. Let's try a different approach this time, and then you'll have everything ready at home, and let's just give this a try together. Yes, instead of saying, you've been wrong all these years, and you've led me astray telling me you had sinus headaches.
I think, it's interesting too. I think a lot of the patients I see come in not necessarily calling it sinus headaches, but do call it sinusitis, or I call it sinusitis without a bacterial infection. And maybe even changing that term to say sinus headache, we're going to give you a headache medicine. There might be a little bit more of a connection. Because a lot of times, you have sinusitis, your sinuses are inflamed, but it's not bacteria, so no antibiotic. Have a nice day. And I think that causes some frustration for sure. Probably because I am missing their migraine headache, but also because...
Yeah. I'm thinking how many patients I had maxed out on topical nasal therapy and having them use a neti pot and all these things that I'm trying to do I've seen patients on steroids I haven't done it, but sometimes the patients will be hitting up the ENT constantly and they end up on steroids. And I wonder if that's treating their migraine rather than actually the sinusitis.
Yeah.
Yeah, I'm encouraged that you would try the abortive therapy first, which I guess makes sense, because I think the other thing is that treating chronic sinusitis the interventions tend to be largely benign unless you're going down the steroid route or sort of blasting people with antibiotics all the time. It's a little bit of intranasal steroids and a second-generation antihistamine. Like, you can feel good about yourself because the patient, you're probably not hurting them, at least. Whereas some of the chronic, I think the prophylaxis specifically, all those medications confer some degree of side effects. But if you're starting with abortive therapy empirically and see if that makes a difference, that seems like a reasonable approach if you're not quite sure what you're dealing with.
The reason these folks come in so set in their ways that they have sinus headaches is, the natural history of a migraine is it may go away in a day, it may go away in 2 days. So they take the antibiotics, they take the decongestants, and they get better just because the migraine's gone away. If they don't get unlucky and then have a long run of migraines, but these things are they're good reasons that the patients feel strongly about getting their treatments.
All right, so I think we've kind of reached consensus on this. Basically, we'll gingerly tell the patient that a headache may be contributing to their sinus symptoms, and maybe a migraine-specific therapy like a triptan could help them, and then that should act pretty quickly. So we could potentially let's do better than this whole 7 years to diagnose this. We'll make a pact with the audience, Justin.
We can, every time we see sinusitis, we can prescribe sumatriptan, and when they get the accurate diagnosis 7 years later, they can take the expired medicine safely, and it'll be fine.
There you go.
Way to tie it all together. I think we have one more case left, Justin, and as with Paul, I refuse to say this name.
Great. So Mr. Tom Phalange cuts his finger on a glass jar today.
I'm sorry. I feel like you went over that last name pretty quickly. So where's our patient again?
Mr. Tom Phalange. He's a wonderful gentleman. He's a big contributor to the clinic. He's just a lovely human being. He comes to the clinic. He needs to have some sutures on his right ring finger, and he needs the procedure. So in your clinic, which you're capable of doing the stitching, what would you recommend as far as anesthesia to prepare the patient locally for the repair? Do we have to avoid epinephrine because it causes digit infarction? That's what I remember learning in med school. So no epinephrine, no xylocaine. We can't inject it there. It's just an anesthetic. Is that correct?
No, I actually think probably the best thing here would be to give this person with lidocaine with epinephrine. Because the person's bleeding, it's going to decrease the amount of bleeding, it's going to decrease the need for a digital tourniquet to control bleeding, and it's just going to make it a lot easier for you to be able to see without blood everywhere. And but certainly the dogma is, and I was certainly taught as a medical student on my emergency medicine rotation, whatever you do, do not inject epinephrine in the fingers, the toes, do not do it on the ears, do not do it in the genitalia. These are end arterial areas where you could end up getting ischemia and, God forbid, necrosis. That was the dogma that I was taught.
Yeah, I've heard similar. So, what's the evidence, or what's the actual evidence behind that? Is there good evidence?
So there was not really ever good evidence behind the ischemia piece with this. Going back and digging back, recently I went digging back into the really old literature, the 40s, and what it looks like happened in those days is that the epinephrine was mixed with a bicarbonate that really changed the pH of the area. So if there were the case reports that were there really didn't have anything to do with the epinephrine. It had to do with other things that could affect the tissue. Subsequently, there just weren't cases in the medical literature of epinephrine over the last number of years being an issue with causing necrosis, causing bad ischemia. And there was an occasional crush injury where the whole hand and fingers got destroyed and crushed, and there was some ischemia, but there really wasn't anything where you could track down epinephrine as the real cause. So this was a case report, sort of tradition, word of God type of thing. And then I think it was about 20 years ago, there was actually a randomized controlled study of 60 patients. They were randomized to get lidocaine with epinephrine or just lidocaine alone for preparation for suturing in the hands. And the group that got the lidocaine with epi actually did a little bit better. They needed less digital tourniquet, and the complications both occurred in the lidocaine alone group. They're not statistically significant as far as complications, but it appeared they were both safe. So that was a nice randomized controlled study, but it was only 60 patients. What's far more compelling is, what do the experts do? The hand surgeons, there's a study that was published, I believe in 2006, that looked at hand surgeons from 2002 to 2004, and in over 3,000 cases of hand surgery where they injected epinephrine as their standard thing that they would use with their bupivacaine or lidocaine, they had no episodes of digital ischemia, and nobody needed phentolamine to reverse the effect of the epinephrine. So that is really the standard of care among hand surgeons. And I've been contacted, when I wrote this up, I was contacted by podiatrists who said, we've been doing this forever. And I found a study from the 1970s by a podiatrist who wrote about his whole career, because he'd been injecting lidocaine with epinephrine his whole career, and they'd never had a complication. And he said, this is what we do. And they talked about the myth in the 70s. But this did not make mainstream medical teaching, obviously.
The podiatry journals are very underrepresented. The podiatry journals really don't get the dissemination they should.
This guy knew all along. It's been, I can't do the math, but it's been a long time, Paul. More than 40 years.
He was ahead of his time, this guy from the 70s. And if for fun, you folks all should pick an article from the 60s, 50s, or 40s. Just read it, because it's just like they're in a bar talking. It's like all the formality of our studies now. It's just a bunch of people saying, we did this because it seems stupid not to. It's like, it's really kind of refreshing in some ways to see people just try to say, I'm going to just get info there. So it's refreshing. It's people are just writing about what they thought and what they did to share that information. But anyway, do that as just a fun thing to do. And for all listeners, if you just want to grin, find a really old article and just read it, just to say things have changed in the way we formally share information now.
That's great advice. I would totally agree. In my limited experience reading older studies, it's more this narrative prose, and it's not in this very sterilized format that we have now. So it is nice to throw some of those references into any talks that you're giving.
Was it the Hyde syndrome with the aortic stenosis and the GI bleeding? Like, if you read the original letter, it was just sort of like, anybody else notice this weird thing that happens? Like, it wasn't like a randomized control study. It was just like, these patients have this, also seem to bleed a lot. That's funny. And like, he got an epinym out of it, so good for him. Like, I'm sure it was smarter than that, but it was fairly conversational.
Well,
I have.
Go ahead.
You just reminded me of another great piece of advice. If you're going to get an eponym named after you, make sure it's not something horrible. Okay, one of you three will probably get an eponym named after you, but just make sure it's something that's not incredibly horrible. Okay.
It's going to for sure be some sort of cognitive bias or some sort of other like clinical reasoning problem. It'll be like the Williams flaw or the.
All right. Well,
I always wanted to have a tumor named after me that leaked troponin, so that anytime there was a troponin elevation, it could be Berk's tumor. I don't know. Could be demand, could be a type 1, but Berk's tumor's on the list.
Amazing. I wish our audience would really make that happen. Let's just start calling that any troponin leak that's not an ACS. We'll call it Berk's tumor. It might be Berk's tumor.
Type 6 in mine.
Well, with that, I think this is a great place to ask Doug if you have any take-home points, and then we'll have to let you go, because I know we're recording in the daytime here, and everyone's got to get back to work, or kids might be busting into my recording studio.
Okay, so just to recap what we've talked about today. So for healthy individuals who are on metronidazole, if they want a drink of alcohol, they can go ahead and do that and feel pretty safe in doing that. Expired medications, pill forms that are past their expiration date are generally going to be fine to take, and especially antibiotics, painkillers should be okay for years past their expiration date. And think sinus headaches equal migraine headaches.
Okay. Doug, thank you so much. This was really fun. Hopefully you're safe out there in Washington State, and you'll get some medical students joining you again in the near future.
Yep, they're coming June 27, so we can't wait.
This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
And we're committed to providing you with high-value, practice-changing knowledge. But to do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecurbsiders@gmail.com. Special thanks to our producer for this episode, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbitelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
And before we go, we should give special thanks to Stuart for composing our excellent theme music, and as well as to Claire Morgan of Nautilus for editing our audio. And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.